Y'all know this is going to be a very dynamic session, right? Anytime we're talking about price transparency and all that other good stuff. I'll start with an apology. I am not from Spokane or Washington. Anyone want to make a guess where I'm from? Atlanta, Georgia. So I bring you greetings from the Deep South, just like you said, and I am delighted to be here with you today. One of my passions, I think, is our understanding reimbursement. I don't say maximum anymore, but what word do I use? Optimum. How are we going to get optimum reimbursement? You all have to talk, or this is going to be very boring. What you think? What comes into your mind when I say optimum reimbursement?
Capturing all charges at full fee.
Absolutely. She said capturing all charges. What else? How about those pesky federal CMS regulations? What do you say about those? I actually agree with that one. But what is interesting to me during all of this COVID that we've been going through is regulations have been changing very quickly. Now we are concerned about if the public health emergency does end on December 31st. I'm thinking it may not, only because we don't have that 60-day notice just yet. But I wish that some way we could simplify, I'm never going to get this signed in if I don't stop talking, we could simplify what is actually required of us. Now, I know that you're going to think I'm weird, but I actually enjoy reading those Federal Register guidelines because they tell us how we can be reimbursed appropriately. We heard from Day yesterday all of the things that we may be doing incorrectly so that we are not reimbursed appropriately. But I just want to share the information with you today. I'm sure I have too much information. But what is surprising to me about price transparency and the No Surprises Act, that about once a week I will have a hospital, sometimes a physician practice, call me and say, hey, Linda, what are we supposed to be doing about this price transparency stuff? Or, gosh, we've not done anything for the No Surprises Act. What should we be doing? So that tells me we simply need to increase our knowledge, understand what's required in the regulations, but then the hard part to me is placing those particular requirements in our procedures and in our workflow so that we are meeting what's required to be reimbursed. Tell me how many of you feel confident that you have both programs in place and things are going well. What would you all say? I don't see a single hand. Oh, I do, back there in the back, 2 or 3. Okay, you please help me because I want this session to be a little bit interactive. As I said, I have a whole bunch of information, but I'm also interested in what your questions are. We are going to have a roundtable a little bit later today, so if you've got specific questions. And I just think it's important for those of us or you who are being successful to share your information with us. So we will work on that. Okay, for some reason I cannot get signed in, which is not good. I'm going to pay attention this time, so we shall see. Here we go. This is all about surviving, and I guess that's the other part that always catches my attention. I have been working with a lot of our particularly hospital customers or clients with whom we are doing business just to walk through the basic requirements only because I think it's important. There are some higher level or a little more complex requirements we want to meet, but I think simply getting the basics in place and understanding what is required is what's important at just this moment. We are going to talk about what's changing. I'm big on compliance, as you heard. Good faith estimates. I probably get at least 3 to 5 questions on good faith estimates on a daily basis. And that tells me we have the information again, but how can we adopt it? How can we put it into practice? There are some FAQs on the No Surprises Act. I wanted to include a little bit of that information. We did get a new final rule in August. You know, we've had 2 interim rules for the No Surprises Act. So now we have a final rule. It's very focused and didn't give me enough information. I'll share that with you, but I do want you to know about that and how it's changed. And then one question I get, and believe it or not, because we work with a lot of self-pay patients, when one of our customer service reps gets a question about the No Surprises Act, that representative will pass it on to me. And what do patients think when they hear about no surprises? Most of them think they owe nothing at all. Have you all encountered that? Okay, I'm not going to play poker with you because you won't answer me.
No surprise act for them to think they don't know anything at all.
And that's a good point.
But that certainly has made it more so.
Yes. I think you're right in that most do not know, but even if they see a small newspaper article or they hear something on the news, I think when they hear no surprises, they equate that with, oh, I'm not going to owe for out-of-network services anymore. So hospitals, I get a question about, are these just Medicare hospitals? And the answer, of course, is no. This relates or covers all hospitals, not just Medicare, and particularly we need to pay attention to your outpatient, your hospital outpatient departments or areas, wherever the locations may be. If they are operating under the hospital's license, then yes, this particular price transparency does cover those locations. As you know, hospital is required to post selected pricing. Pricing to me means your charge amount in 2 ways. Either the machine-readable file, notice that it says for all items and services, and then a consumer-friendly, shoppable services file for the 300 most common items and services that you are providing. The or to those 2 requirements is, of course, you can use a price estimator as long as it meets all of the guidelines that I'm going to mention to you. And again, I'll say information must be available on your website for each hospital location. Now, also let me say that if the pricing is different, and most of the time we find out what? It is different, because we'll say, oh, we have this location in a more rural setting, the charges are going to be slightly less because my cost in that area may be slightly less. If I'm in a large urban area, even if I'm the same hospital, my pricing or my charges may be greater, again, only because the cost is greater for those. And then, of course, we want this information to be visible at every hospital location, and particularly in the areas where patients are either being registered or where they are being given cost information. Machine readable file, I struggled with that one for a while, but finally think I have an understanding of what that means. And look what we are supposed to have as part of this price transparency. Standard charges that include our gross amount of the particular charge for each individual item. If we offer a discounted cash price at any time, that needs to be shown. Payer-specific negotiated charges. Now that one has been a nightmare from some of the hospitals that I've worked with, but I think, and you disagree, but sometimes I think we don't even understand our own contracts as far as how we are going to be reimbursed appropriately. And then we need a de-identified, a minimum and maximum negotiated charge. Again, requires some digging. I've had several hospitals say to me, gosh, Linda, we need 3 full-time people just to keep up with this pricing transparency. And I don't say that that is not feasible, because what do? A new physician comes in, we add services to our charge master, our charge system, we change, we buy a new piece of equipment, perhaps we upgrade the services that is being provided. So any of you who are involved with charge master maintenance know that we go through a lot of daily revisions or additions just because of how our services are also being changed. Just a little bit about a package, and many of us do have specific charge packages. Make sure that you are showing that package with some type of asterisk or something that says, yes, this is a particular package charge, and here is what is included in that package. I think that's very important. And then we want to talk about shoppable service. Is any service, item, supply, implant, test, exam, anything at all that can be scheduled by a healthcare consumer, I would call that consumer a patient, in advance. And think about, sometimes I look at charge masters with what? 30,000 line item charges, not unusual, but you really want to understand your volumes. What are patients ordering or needing for patient care, so that when you zero in on your 300 shoppable services, you know that you have the ones that your particular patient populations are going to be looking for. Okay? As I mentioned, we need those 300 common items and services. 70 of those were sent to us by CMS and said, please include these. And then the other 230 you come up with on your own. So let me stop right there and see if anybody has a question. Okay. The price estimator, I get a lot of questions about, and there are some very good ones. But understanding that this particular requirement from the federal government is for an online tool that provides real-time, individualized, out-of-pocket cost estimates, and it is specifically for that individual patient or whomever they are scheduling a service for. We must come out with a single dollar amount tailored to the individual demographic, personal patient information. How well do we do with entering, when we, on the hospital side, are entering personal demographic information for our patients over there in patient access or registration? Are we good at it? I would say no, because I'm back there in the business office cleaning up those claims that perhaps have some either missing or incorrect patient demographic information. In this case, our patient is entering, but at the same time, I have one hospital who truly has reviewed their estimates based on the information they have, if that patient has ever visited them before, the demographic information they have versus what the patient has entered. I don't suggest that you do that, but it's an interesting approach to me, that if the patient is saying, here's my info, what do we have in our system that perhaps does match that or does not? It must reflect the amount the hospital anticipates will be paid by the individual. So patient responsibility. How easy is that to get to? Depending on your tool, of course, but also depending on how accurate your charge information is that's posted on the website. How frequently, as I mentioned to you, is it being updated so that you understand if I'm giving out an estimate on a screening colonoscopy today, is my charge data that's in my tool, is it accurate? So again, I'll just say, because I get questions about this one, this must be a real-time, individualized, out-of-pocket estimate that combines the hospital standard charge with the individual's benefit information. So we're looking for a very specific amount. Here are a couple that CMS has said do not comply. Estimated average charge amounts or ranges for the price of a shoppable service based on a broad population of patients. In other words, we can't have. This is my average charge. I see this sometimes, my average charge for every payer with whom I have a contract. CMS is not going to accept that. Total patient responsibility that does not combine that standard charge with the individual's health information from the specific insurer or health plan. We just go back to that. I guess I can't say it enough, only because when I'm seeing some errors, and we'll talk about those in just a moment, oftentimes it's because we do not have the appropriate or latest standard charge. We also can't have a disclaimer stating the price is not what the hospital anticipates this particular patient is going to be obligated to pay. Keeping in mind the 5 pieces of data or information that are required regarding your charges, and then these specifics that CMS says we cannot have. Does a hospital have to report standard charges for physician and non-physician practitioners? What do y'all say? Shake your head yes. Okay. And this is, again, think about how very specific this is. We work with some hospitals that have 1,500 physicians, and understanding and these are employed, of course, employed physicians, but understanding what that particular practice, even though owned by the hospital, their charges, I often will see the charge master, or actually it's a fee database over in the physician practice, is not maintained by the hospital. But we still have to understand what those charges are in order to be able to include that employed physician's charge within our particular pricing structure. A lot of times someone will say to me, okay, Linda, you've said employed physician. What does that mean? Well, interestingly enough, even though we have an FAQ about employed physicians, CMS did not give us a true definition. They simply said, just think about the IRS definition. What's the difference between a contractor and an employed physician? Okay, is there a limit on the number of third-party payers that are reported? And the answer to that one is no. Hospitals are required to include all payer-specific standard charges for all their items and services, an extremely large undertaking. If the hospital does not have a standard charge for some items, for example, a gross charge for services in a package, should or can that hospital report an average charge? And as you see there in bold, average charges based on prior years would not be acceptable according to CMS. So I'm just simply back to that definition of very specific patient demographic based on a specific charge for the service. And this is where CMS talks about negotiated charge rates. It is required for each item or service, in addition to the gross charge, just like I read those 5 things to you, and that de-identified minimum and maximum charge. CMS has said in this particular information, you cannot just put an NA there for inapplicable. We need the charge amount, which is always interesting to me. Enforcement, here's where I want to get your attention as well. We did have warning letters go out in 2021 and some this year, 2022. To begin with, our penalty was going to be $300 a day for all hospitals. However, January 1 of this year, the penalty has gone up to a sliding scale based on your number of beds or bed count. Up to 30 beds is that same $300 a day. If you have greater than 30 beds, the penalty will increase by $10 each day for each additional bed greater than 30. So this is the one that gets my attention. A maximum would be $5,500 a day. Now, that's a completely different penalty than $300 a day, right? So here's where I start paying attention to, do we have all of this required data or information posted? And the next step, I think, is, does our staff, our team members, do they understand when a patient calls in with a particular question, do I have someone who can answer their questions and help them either with the price estimator tool or get to the particular service they are asking about? We must have those knowledgeable people in the workflow so that our patients can get individual attention when they have questions. Back to the penalty, a full year of noncompliance, total penalty may be between $109,500 or, for very large facilities, $2,007,500. And of course, as I mentioned, those are the ones that get my attention. I think Day mentioned yesterday, we still have between 30 and 40% of our hospitals who have done nothing about price transparency. I would be concerned, of course. And again, I'm not standing in front of you saying, oh, I have a magic wand, here's how you can get it done. And a lot of the questions I'm being asked are very hospital or facility specific. So I'll be around all day today. If you have questions, I mentioned the roundtable we're going to have, I believe, at 1:30. But I think I just want to get across to you how important this is. I too started thinking out, price transparency sounds like a good thing, not realizing all of the attention to detail, the time, effort, and as I mentioned, the energy in keeping this information current, up to date, and accurate. We did have 2 hospitals, interestingly enough, in Georgia, a hospital that I know very well, who have been fined in 2022. One fine was $880,000, and the other one was $214,000. And I do believe, not trying to scare you, but I do believe many more fines are coming, which is why I see this as a very important requirement. Okay, price transparency. Any questions?
Linda, with the end of the year coming and some hospitals potentially having price increases, is there anywhere that you have to notify or let your shoppers know that subject to change or new rates starting or whatever?
Yes, I have seen one hospital already post a note on their website when you when you first get there and you're going to put your patient information in to get an estimated patient responsibility. It says, posted charges are good through December 31st. January 1, charges are going up 2%, whatever the case may be, and those will be posted. They're actually going to have 2 sets of charges, one that is identified as through December 31 and one that picks up on January 1. So that's a great question. And see, that takes so much planning and so much understanding of how can we use our system to provide the information that is required, as I mentioned to you.
The reason why I asked that is because you were mentioning about having somebody available to answer those questions.
Uh-huh.
They're going to have to explain, well, if you're here part in 22
Yes.
and then you in 23,
Yes.
I expect this to happen.
Completely agree. There's so many supporting pieces of information that are needed, and that, like I mentioned, your particular team members, whether they're in patient access, PFS certainly, whether they're following up on particular claims. I just think this is requiring, and I have seen with our clients, this is requiring much more training than I realized at the beginning of this journey to get all of this done. Am I making too much of it? What do y'all say?
Is not you, it's the government.
That's true.
I really think, just commentary, I think this should have fell on the insurance companies, not on hospitals, because they're the ones that, I mean, they have all the information there, in my opinion.
They have all the information. They probably do have all our charges. I just think, personal opinion, all of us providers get more and more responsibility, and the others involved, particularly in payment, aren't held responsible for some of this information. So I agree in some respects. And I guess from the patient perspective, what do all of my relatives do the minute they go to a doctor or they go to hospital? They call me and say, what in the heck does this mean? And I think it is very confusing. I mean, I looked at a remittance advice last week from one of our clients. It made no sense whatsoever. And then when we send a claim, what do we put at the front? This is not a bill. I just think I'm enough of a patient advocate to say, yes, this is needed. I just don't think anyone realizes how difficult this is to do. I know all of you that are working on it, and some of you have achieved it. I know you understand, but I wish there were more, I don't know, just more understanding, almost, countrywide, of what we are being asked to do in this particular circumstance. And I'm all for calling up your senator or your House of Representatives and letting him or her know we need help with this. Sometimes I think that falls on deaf ears, but I have seen some of our hospitals be successful, either working through HFMA or working through, the State Hospital Association, just communicating, okay, come spend the day with me, Mr. Senator, and let me show you what we have to go through in order to meet this particular guideline. And I know all of us don't have a lot of time to do that, but I want it more, like I say, universally known what we are doing to get to these price estimates. Okay, I'm going to change just a little bit to, oh, I'm sorry, yes.
You mentioned on one of your slides the de-identified minimum maximum charge. Is that necessarily the either please define that, or is that the de-identified minimum maximum negotiated rate?
Yes, I would say negotiated rate.
Okay.
If you have in your contract that a patient in the ICU, regardless of diagnosis, length of stay, here's my negotiated rate for that particular patient, just because it is a particular payer, is $1,100, that would be both my minimum and probably my maximum negotiated charge.
Yeah.
Does that help, or you have a particular?
No, that helps. Thank you.
Okay.
And I would say regarding the question or the statement on the insurances, two things. One is, in particular, insurance doesn't necessarily know what each of the individual's volumes are like and what their 300 top items are. But on the flip side of that, this just goes to show you that the insurances have a better lobbying effort than the hospital association does, and they've proven that time and time again.
Agree. I do think that's a good point as well. So we're going to talk about just a little bit on the good faith estimate again. Oh, I'm sorry. I need to look up, don't I?
I was just going to say, as a healthcare consumer, right? You are at the doctor's office. You're at the hospital, and so when they're asking, do you want to do this thing, whatever it might be, I mean, that's when you need the information. To put it on the insurance company would not help the consumer at all. And I don't think it's simple by any stretch of the imagination. I think it's very difficult I took my, maybe I've told this story before, but I took my son in for a knee injury. They did x-rays. They said, well, there might be soft tissue damage. There's nothing broken. They said, we could do an MRI. I said, how much is that? He said, I have no idea. Do you guys have an MRI system here? No, you'd have to make that appointment someplace else. What would the treatment difference be? Well, we'd probably wait and see either way. So, I mean, there was no good way to make a decision in that case, right? And I get, like, there's co-insurance involved, coordinated benefits. It's a hard question to ask the doctor, but there's never a good answer. And just from the consumer side, I think it's frustrating. Not that it's an easy problem to solve at all.
Agree. I do. And I think that's why we are so concerned about accurate, price estimates or what the patient responsibility is going to be. But I almost feel like this has complicated it even more. And now with the responsibility placed on providers, it's going to cost us reimbursement. That's how I see it. Okay, good faith estimate. As of January 1 this year, we must provide a written good faith estimate.
You got a second? I'm going to go back to that consumer part of it, because I think one of the biggest challenges that we have is the fact getting the demographic information. So we may talk to the patient who's trying to we're trying to provide a good faith estimate, and they have Blue Cross. And that's probably all the patient knows. Now, unfortunately, we probably have 20 different Blue Cross plans with the same payer, or Blue Cross may be the TPA for the self-funded employer, so we have no idea what that benefit plan is to do it, and the employee has no idea what their benefit plan is to do that. And I think that's one of the biggest complications of this whole thing is there's too many variables, especially from trying to identify the benefit plans within an individual payer, which they all have multiple ones to do that. So it's almost I think it is an impossible task to do that.
I agree, and I hear from a lot of particularly hospitals that even though I can tell you I'm covered under Blue Cross, I'm seeing more and more, yes, I'm eligible for Blue Cross coverage from January 1 till December 31, 2022, but my particular plan requires a medical service before I can move on to that MRI. To me, our identifying eligibility or just plan coverage does not mean that that particular service is going to be reimbursed anymore. Too many requirements. Orthopedic doc calling me a couple of weeks ago saying, okay, Linda, just like Day said yesterday, we had a prior authorization for a hip replacement. Surgery went well, but my patient is a little bit older, and she's not recovering her ambulation as well as I want her to, even though she's been to rehab, all those things. So they did reach out to the payer. Payer says, okay, she needs to go to a therapist, have an evaluation, and submit that for authorization. Sent patient to the therapist, got a plan of care, 8 weeks, I think 2 times a week or something like that, and simply started providing the therapy evaluation because according to the doctor, the payer had pretty much said we will approve whatever that therapy plan of care may be. But what happened? Send in the first claim, they deny it because the therapy plan or the evaluation was supposed to be sent for another prior authorization before the care actually began. Now that drives me crazy. And if there are any payers in the room, if you want to stand up and speak up for yourself, please do. And then now here's the other one, and I'm way off the path now, but here's the other one that got me just a week or so ago. I have an oncologist calling me saying, okay, Linda, what are you going to do about this? There's not anything I can do. But he says, okay, my patient clearly has a cancer, terminal diagnosis. I write a script for this particular drug, chemotherapy. She comes into the office, she has the administration, I send the claim, and the payer says, oh no, you can't administer that drug until you administer this lower cost drug and see, what the patient's reaction or how they fare after this lower cost drug. Now, what cancer patient who is terminal wants to hear that? I can't get over, and my other big deal these days is if you don't understand what's in your contracts, we have a more difficult time with Medicare and Medicaid, but at least we get quarterly bulletins from them, or we can go out on the website and find out what the coverage criteria are. But I'm seeing more and more either previous patient care required for a higher level service, or I'm seeing something where a physician has to document a very specific. Now think about all the years that we asked for ICD-10. Has it helped us? When I can find that physician who documents everything to a T, yes. But a lot of our physicians, just like we mentioned yesterday, do not have a good EHR template. In other words, we may not be asking the right questions for such a specific plan of care or procedure, or our physicians simply may not document well. Now, I know all of our customers with whom we work are working on clinical documentation improvement, but it's getting more and more important that we understand from our contracts what's required in order for this particular patient to receive the care that has been ordered by the physician or other provider, so that we know we are going to be able to be paid. And that's just receiving a payment. I haven't even moved on over to calculating the patient responsibility. So I don't say it's impossible. I do say that it's very complicated, and think about all the job roles that you must work your way through to know we have an order for this particular service. I'm seeing hospitals move part of what they are calling patient care management, which is our previous departments of utilization review, discharge planning, what's the other one? Case management. They're moving some of those clinicians into the revenue cycle, particularly patient access, so that a knowledgeable clinical person is reviewing to see, okay, this is what this particular insurance requires. Do I have all of that? Is it documented in my record? Am I going to be able to be paid for this sometimes very expensive service? So we are truly down, what I call down in the weeds, with determining whether or not this particular payer is going to cover this service. Okay, where am I? Any other questions? Who is the good faith estimate required of? All state licensed or certified healthcare providers and facilities. And actually, for the first time ever, CMS includes that word, everyone. And then we have the definition for convening. What is a convening provider? That would be the hospital who is scheduling an outpatient surgery with a particular surgeon. So as of January 1 next year, 2023, even if that physician is not employed by us, we must include in our good faith estimate our charges, any anesthesia, any, supplies we would have already had to include, but then the actual professional charge for that particular physician or surgeon providing this service. And I think that's what that says. Beginning January 1, the good faith estimate must include any item or service that is reasonably expected to be provided in conjunction with a scheduled or requested item or service by another provider or facility who may be a co-provider or a co-facility. That's a hard one for us. Health and Human Services supposedly was very generous with us and did not require that as of January 1 of this year, but it is supposed to kick in, and I think it's in the inpatient final rule that it will begin on January 1, 2023. Provided to whom? Again, self-pay patients, uninsured, and of course the patient always has the option to decide whether they want to use their insurance coverage or not. And sometimes I'll run into that particular provider that if that patient does not want to use his or her insurance, they may be self-pay, and the discount for a self-pay patient may mean the patient will pay less than if they used their insurance and hadn't met their deductible or some other reason. Then they're going to end up owing more than if they actually just say, okay, I'm self-pay, please give me your self-pay discount of 40% or whatever the case may be. And here's the timing, which I always have difficulty with. A provider must provide a good faith estimate when scheduling or upon request within 3 business days of scheduling if the service is at least 10 days later. So I have my 3 days. It must be the next business day for my good faith estimate after scheduling if service at least 3 days later, but less than 10 days later. And then it also must be within 3 business days of receiving a request for a good faith estimate by that uninsured or self-pay individual. So you probably need that information posted just to remind us all of what's required as far as when the good faith estimate needs to be provided to the patient. What format does it have to be in? It must be either in writing or electronically, depending on what your patient requests. So when we're communicating with that patient or when we are providing a good faith estimate from one of our websites, we need that question. How do you want to receive this? Do you want to receive it in the mail? Do you want it electronically? All of those questions, I think, go into, as I mentioned to you, whether or not we are meeting these particular requirements. What if our estimate is inaccurate? Now, this one gets my attention as well. Patients can challenge our bills substantially in excess of that estimate via a government dispute resolution process. Substantially in excess means what? Actual patient responsibility is in excess of $400 or more than the good faith estimate we provided. Now, $400 to me is nothing, right? That could be just a routine drug of some type. So understanding accuracy, I think I mentioned to you beforehand, is extremely important so that you have confidence in those estimates that you are providing. The provider who does not provide an accurate estimate may be subject to civil penalties, $10,000 per violation. I'm just good news today, right? What are some hot topics that I've been asked about recently? Of course, you have to have a notice of a good faith estimate on your website, just so that the patients know here's where I can go to get an estimate. On site where scheduling or questions about cost of care may be carried out. You must update your good faith estimate if anticipate changes in scope or estimate. Now, I've been asked about that one a lot recently. The only good example I have come across is if my patient wants to schedule, or the physician wants to schedule a particular procedure before the doctor sees the patient and evaluates him or her, then even though we have sent a good faith estimate for a particular procedure, if that physician decides after his or her examination that procedure needs to be changed, then yes, we're going to have to change our estimate, if, depending on that time schedule that I gave you. Recurring services, this one is kind of good news, can use a single estimate for up to 12 months if my patient is going to have that therapy for 8 weeks or whatever the case may be. We do consider that estimate, even though it is a financial form, we consider it to be part of the medical record. We want to be sure that's filed along with the patient's care. Must provide copies of prior estimates to patients furnished within the last 6 years. How they came up with 6 years, I do not know. We are looking for more rules for providing a good faith estimate to insured patients per the patient's coverage plan. I thought that we would get those in the final rule that was just issued in August, but we have not. So just more information to come. And that's the other part that has been difficult for me with both price transparency and the No Surprises Act is we'll get some information, but we never get the entire picture all at one time, which I think requires us to be, just a little more direct with our education. Is a provider or facility required to provide a good faith estimate to uninsured or self-pay individuals upon scheduling a same day or even a walk-in service? Now, I like the answer to this one. It says no. If the item or service is being scheduled fewer than 3 business days, as I mentioned to you, before the date of the item or service is expected to be furnished, then we don't have to provide that good faith estimate. Let's see, what do I have on this next one? I need to hurry, I know. Providers or facilities need to provide good faith estimates to all individuals. And I get this one a lot. Must I give one to a Medicare or a Medicaid patient? The answer is no. We're still with uninsured or those choosing not to use their insurance if they request one specifically. Let's see, uninsured, I think I've given you that definition. Self-pay, certainly. Under the No Surprises Act, providers and facilities are generally not required to provide estimates to individuals insured under either Medicare, Medicaid, or any other federal program. Again, a little bit of good news. And this one is all about reasonably expected to be provided. So there is a little bit of leeway for those procedures that may be added on during the actual provision of a service. I just think this one, you don't want to let this particular requirement lull you to sleep. If the physician provider already knows that certain services are going to be part of this patient encounter, then we certainly need to have that in the good faith estimate. Okay, this one gets my attention too. Do providers need to factor in financial assistance an uninsured or self-pay individual may receive when calculating the expected charges? Guess what the answer is? Yes. So if my patient is already established as a charity care or a particular discount under any other program, I need that information in my system to be used in this price estimator or the price patient responsibility that I'm coming up with. And that's hard to me. I don't know how you all see that one, but it's definitely difficult to be sure that we are capturing that. Any adjustments expected to be applied under the financial assistance program or plan would be, I would say, must be factored in and reflected in the amount of that good faith estimate. So I do think the further along you are with price transparency, it certainly helps you with our moving on to the No Surprises Act and talking about out-of-network. But understanding what's required specifically for price transparency and how you can use that, I do think is important. Surprise billing, a lot of this again is fundamental. It's interesting to me. The first time I actually read the No Surprises Act information or regulation, I should say, I thought, wow, this may actually be good for those of us who are providers or facilities. But what happened along the way? I just think the original act allowed some understanding of what a particular provider should be paid in a fair payment qualifying amount. Okay, let me move along a little quickly here.
Quick question.
Yes, sir.
Quick question. And for your self-pay population and for this good faith estimate. If you're able to get that patient enrolled into the state Medicaid, does all this go out the door? No longer do you have to meet that requirement and do any of these types of things?
True.
Okay, that's so
Now,
that will remove
but-
it off your plate.
And then the only thing I would say is that requires what? Medicaid to move a whole lot faster than I'm used to Medicaid moving.
Yeah, absolutely. Even more so now. Yeah.
Okay. Yes, sir.
So across the room of providers, like, where is everybody at with this? Have you guys already started to think about this process? Are you already doing any of it? Or
Which one?
Yeah.
Pricing transparency or no surprises?
this good faith estimate that's
Oh,
coming in like a year? Are people already you were going to say?
Yeah, and we started it January 1. I think we're providing around roughly 300 to 500 a day to our self-pay patients, and we're at 97% accuracy, and we've had one dispute filed that we know of. But HHS is really, really behind, so they have hundreds of thousands sitting and waiting that people have filed disputes for all over, and they can't get to them. But yeah, we're pretty confident in our estimates.
So how do you deal with all those affiliated physicians?
That's not a requirement
That's not a
yet.
requirement?
No, convening providers is not a requirement yet. They've delayed that, so we just have to provide the estimate for our services that are being provided.
So you're not trying to do that convening part of that?
Not yet, no.
Do you guys have a plan? I'm just wondering, do people have a plan for that?
We have a plan, but there's not a platform. So they have to provide a platform for us to be able to communicate, and there's not one that exists yet.
Who has to?
CMS is supposed to provide that.
and she's absolutely correct in that our biggest issue, I've tried to stay away from, and we haven't really gotten to the independent dispute resolution and the portal. CMS has just had terrible problems coping with all of this, which, as I thought, perhaps would give us a little more delay in meeting some of this, but it has not. But if you have specific questions on, filing a dispute, going through the arbitration, I'll be glad to help you with those. And we've got several customers, clients who have been successful, both with price transparency and with good faith estimates and with the No Surprises Act. It just gets my attention that how hospital specific every one of these has to be, because your payers are going to be different than my payers. My charges are going to be different from your charges. Your physicians, I haven't gotten to the slide yet, I don't think, but there are some physicians that can't get a consent waiver signed. So they are not going to be able to balance bill, even though we know, they are not part of the network, so to speak. So I think that the challenge is individual differences, but at the same time, just simply understanding, as your question, where are we with this particular step in this process, so to speak? Yes, ma'am.
I was speaking to someone yesterday who just signed up to be one of those independent dispute resolution entities.
Yes.
And he is hearing from other entities who are getting up to 150 to 400 requests a day for dispute resolution.
Right.
And they're finding that insurance plans are not participating, so the providers are actually winning by default. They're getting ghosted by insurance plans who are not even paying for that. When they lose, they're supposed to pay that entity fee. They're not hearing from them. They're talking about taking insurance plans to collections to get this anywhere from $250 to $500 that they're due.
What I am reading, well, I have heard that some payers are not responding, just like as you said, but I'm also reading in this new final rule for the No Surprises Act that payers are going to be held more responsible. Now, I've not heard that information about they're going to be taken to collection, but I think they have been overwhelmed, just as CMS has been overwhelmed, because of that qualifying payment amount. We, on the provider side, are not going to accept that qualifying payment amount unless it is somewhere close to covering our cost. That's what I hear every every time I see a payment coming from a particular payer. But I think what we need, and I think I mentioned before, I really want CMS or the federal government, Health and Human Services, to step in and make the payers more responsible, as you're mentioning. First of all, I have some hospitals that can't even get an accurate enrollment for a particular plan. You know, Linda will walk in and say, yes, I have Blue Cross Blue Shield, whatever, here's my plan number, but when the hospital contacts that particular payer, generally through their website, I'm not listed, even though I have a current ID card that says I'm eligible, that I have coverage. So there's so many problems that are being encountered, I do believe. However, I have to stand here and say, I don't know that that is going to help us when it comes to all of these fines, if that makes sense. If we have done our due diligence and complied, much as she mentioned in the back, we're doing our good faith estimates, we know we're 97% accurate, I think that's going to be our only defense, so to speak, that yes, we understand what's required of us, as I mentioned to you to begin with, and we are well underway with complying with what's required. We may not be able to, but if I have submitted that request to a payer to find out if a particular patient is covered and they sent me back incorrect information, then certainly my patient responsibility or my good faith estimate is not going to be correct. Does that kind of make sense? It doesn't make it easier for us, it just makes it more specific with what we should be following through in order to meet the requirements that are provider specific. I want those payers to be more responsive. I want them to have accurate information and share that. But if not, I'm still responsible for the parts of the regulation, the law that applies to me. Anybody can disagree, make comments if you like. Yes?
Do you want me to wait? Hello? Oh, now it's working? Oh, okay. I was just gonna add to, for the federal law states that you can ask the patients to waive their balance billing rights for out-of-network or their balance billing protection. But in Washington state, we are not allowed to ask patients to waive their balance billing rights.
I'm sorry, in Washington state, you're not allowed to what?
Ask the patients to waive their balance billing protection in Washington state for out-of-network.
Okay, now what I read was the federal law was going to take precedence for Washington, but and I'll be glad to go research it a little bit. But
that would be good to know, because I as far as we've been operating under, it's that Washington State made it so we couldn't do that.
I will certainly find out. And my email address is on the front of this presentation, and I see that my time is almost up, so let me go over to a whole bunch of slides. You know about the one-page notice, I hope. This is about arbitration, extremely important. And please, if you do receive a payment that you think is less than appropriate, I don't want to say fair, because my husband tells me that fair is where you go for cotton candy. It is not life. But if you know your cost, and most all of you do, and your payment is less, please dispute that, as much of a headache as it is. So we've had 8 lawsuits. Only one has been settled regarding particularly how the qualifying payment amount is defined. And now we are down to, let's see. Here we are. It focuses on the process for this independent dispute resolution. However, the part that gets my attention, that IDR entity is instructed to select the offer that best represents the value of the item or service that is under dispute. Now that makes a lot more sense to me than the median contracted rate that has been paid by that particular payer for your location or the area in which your patients are being served. So this is almost just a little bit of good news, but I'm hoping that it will be taken to heart so that we see these IDR entities understanding I need to not disregard the charge, which is what one of the interim rules said, but truly make an effort to understand what should this particular service or care, what should it pay back to the provider simply for us to keep our doors open. Because I think the way reimbursement has been headed, particularly the last 5 to 7 years, we see reduced payment every year. And at some point, particularly, I don't know if you look at the rural hospital percentage of closures, or even some of our very large systems are truly struggling. So I have some renewed hope, I think, because we got this new final rule. Of course, we have to wait and see how it's going to be carried out. And I want to mention to you credible documentation about the acuity, the sickness of your patient, and the level of service that you provided. I'm back to that ICD-10 dilemma, because if you are not able to support, this was a more complicated procedure because of a comorbid condition the patient had, or because of level of care that was needed. I think that's how we're going to get our payments increased in order to stay away from this, qualifying payment amount. And I am definitely out of time. One of the questions I got just last week that I'm interested in mentioning to you is, please work with the individual or the team within your particular facility to be sure contracts are very well spelled out and you are asking, for some good results through those contracts. And I know how difficult that is, but make sure whoever in contracting or risk management, wherever your contracts are being reviewed, signed, agreed to, get in and get some of those terms that will assist you with making sure your reimbursement is going to be, I'll use the word appropriate, or I'll go back to optimum for the services that you are providing. I apologize for having way too much information. As I mentioned, I'll be here to answer any questions to my very best ability for the rest of the day. And please email me. I know you think I'm crazy, but it's fun for me to see what questions you have, be able to work on those, and then simply communicate like you're doing here today with the hospitals or providers with whom we are working to perhaps answer some of your questions that are coming about. Anything at all that I can answer quickly? I hope this has been good. Good info? Okay. I'll turn it over.